Majerison here, welcome to Top Med Talk. Today's presentation for you is from Helen Anderson. It's CPET and shared decision making, and it was part of the POETTS annual congress, which was held at the Institute of Engineering and Technology this year at the beginning of July. Have a listen.
Top Med Talk.
Welcome back to POETTS 2018. This session's on the other uses of CPET. And first up to speak, we have Helen, who's been involved in CPET both for pre-op and for research since 2005, initially starting in Newcastle, now down in Cornwall. And Helen's going to talk about shared decision-making and CPET. Helen.
Thank you for inviting me to talk today. My journey in CPET's been going on for quite some time, and as has my input into shared decision-making. And I've probably thought for quite a long time that I've been doing this quite well. But you begin to realise that there are nuances and things that you can learn and continue to improve with. So if we think about shared decision-making, we've already had the doyen speaking on this stage earlier this week, which gives me no comfort whatsoever. But it's been talked about for a while now. So back in 2010, we started talking about this shared decision-making approach, and then moving it on to no decision about me without me. This is a big driver within the NHS, and there are many people that are pushing this agenda now. The Lanarkshire Montgomery case has made the surgeons sit up and think about it, and the Royal College of Anaesthetists is also hugely supporting this. And so in conjunction with MAGIC, which is a training system based on shared decision-making, supported and developed by the Health Foundation and groups up in Newcastle and in Cardiff, they developed a programme so that we could start to teach healthcare professionals in a relatively short space of time some of the important concepts that are involved in this, and also how to embed this in your day-to-day clinical practice so that it doesn't have a huge impact. And also think a little bit about the barriers that stop people choosing this different way of approaching patients. So in the end of 2017 and 18, the Perioperative medicine group within the Royal College set up a couple of sessions to start to train us up so that we could be trainers to train other people within our communities. So I went along and we saw lots of things, and we started talking about the sort of patient preferences and actions and how important this is to think about their goals and how you combine this with research evidence and the clinical state of the patient to come to this area of expertise. And it seems at the moment everybody's showing Venn diagrams, and they seem to be a very popular way of looking at things in life. And so I thought, well, in that case, maybe I need to come and think about how we do shared decision-making in perioperative medicine and think a little bit about all the important components of that. And at the top of this needs to be the patient, and it is about identifying what's important to them, about thinking about what their values and goals are. We also know it's part of what we're doing is looking at the options. And in perioperative medicine and in pre-op assessment, we often don't have the biggest idea of those different options. And part of that evolves as your practice evolves, and part of that is about knowing the people within your environments, within your hospitals, the people you need to ask and you need to talk to get these options together. And then I think this is where the CPET comes in. We're starting to offer this opportunity of individualized risk assessment. It's beginning to give us more objective information so that we can help the patient balance up the risks and benefits of surgery to them. And as I said, I think it's really important to know your surgeons, to know what the options are, to be able to discuss with them different options that could be available to the patient depending on the fitness and the assessment that we've made of them. And I think the oncologists are also important, and there are many other healthcare professionals that we need to get opinions and advice from to help provide the right options for the patient. And hopefully, if we get it all right, we'll end up somewhere in the middle of this picture, and we'll have the right decision for that patient at every consultation. We saw some pictures earlier in the week about the shared decision-making process, and it looked quite linear, and this is a later production that suggests that it may not be linear. It's a more circular process, but there are 3 key elements that you need to involve in this. And you need to think about the team talk, about finding out about your patient, about what's important to them and what would be a bad outcome and what they don't want to see happening. You then need to have the options talk. And when I see you, I mean the perioperative team. You will have some of the ideas about that in your practice, and it may be that you need to go to consult others about how you can approach that. we're also using that in with the information that we've gleaned from our assessment process. And then finally, we talk about the decisions and help the patient work through and find the right decision for the right treatment for that person. And you can see 10 different people with exactly the same CPET numbers, and you may have 10 totally different discussions, conversations, and outcomes from that. So I'd just like to talk to you a little bit about a lady I met just before Christmas called Sarah. She was a 75-year-old lady who had unfortunately presented with quite a nasty cholangiocarcinoma and was being worked up for a possible liver resection in order to treat this. She'd been pretty unwell in the 6 weeks preceding the time I got to see her, having presented initially with obstructive jaundice. She'd had some stents put in and she was starting to feel a bit better. She was actually pretty fit and well, and apart from a panproctocolectomy 50 years ago, she didn't really have any other medical history. However, she'd been really poorly over those 6 weeks. She admitted she's never been a big lady, and maybe 50 kilograms was the height of her size at any point in time, but she dropped down to 38 kilograms. However, she'd been feeling better, she'd been eating, and she'd been improving. So, having just come back from one of the shared decision-making talks, I was like, right, I need to be taking this into my practice and working differently. And so I invited her into the room and said, how do you feel about this? The surgeons have talked to you about the idea of having a big operation. How is this making you feel? And it was a bit like the floodgates opened. All of a sudden, she just sat there and said, I don't want an operation. I don't want to have this done, but my husband is desperate. He's older than me. He's in his 80s. I'm supposed to be looking after him. That's supposed to be my job. But I don't want to do this. When they told me it was cancer, I just wanted to have palliative treatment. And she admitted that it had left her feeling incredibly conflicted about what her desires and what she wanted to do were compared to those of her relationship with her husband and how they were going to live and grow old together. This was in the first sort of 3 minutes of arriving. It also turned out that her husband actually hadn't been to many of the consultations that she'd been to, so they'd seen teams in a different hospital, they'd seen the surgical team. She'd seen the surgical team in the hospital where I work, but he didn't really want to get involved. So she also wondered whether he'd actually got an idea of what was really going on. And she tried talking to him, but she felt that he didn't really understand what the risks of the surgery were all about as well. And all he was thinking was that you've got to have the operation because you've got to get better and then you've got to come home so we can live together again. And then I asked, what do you see happening? Where would you like this to go? And she said, actually, I've got 4 dogs. My husband can't look after them. I want to be there for them. I want to look after my dogs and I want to die a dignified death. So I'm sort of sitting there feeling a little bit conflicted. This is difficult. So I said, well, okay, let's move on to the next bit. What would be the worst outcome from your perspective? And she said, well, actually, one of my friend's husbands came to this hospital. He had a liver resection. He didn't get better after surgery. He was on the intensive care unit and he died without ever waking up again. I really don't want that to happen. This was difficult. I already knew that we talked with the surgical team that her surgery was going to be quite extensive. It was going to be very high risk, and that this was a very distinct possibility that could be an outcome for her. And we discussed that that might be a possibility. She also said very straightly that if things didn't go well, she felt that she would have significant regret. So at this point, I'm thinking, well, what should I do? You're here for an assessment and a special bite test, and I'll carry on. We'll work through the options. We'll make sure that you're aware of them all. Now, I'm lucky where I work. I go to the joint planning meeting with the surgeons in hepatobiliary medicine. So I actually knew this lady was coming. I'd seen the scans. They talked about this was resectable, but it won't be challenging. She was lucky because she had a very large left lobe of liver. And so if they were going to do an extended right, the feeling was that she would have a good volume of liver left, reducing her risk of some of the serious complications of the surgery. However, because she's been so unwell, because it's a cholangio, because she's had jaundice, because the stents were there, they were thinking that the risk of this may be up to 30%. 30 people in 100 may die if they have this surgery. So this was no mean undertaking, and we were entering into this discussion with me knowing that the surgeons weren't sure they wanted to do this, The patient now wasn't sure that she wanted to do this. So did we really need to go any further? So we had a little further talk. Oncology had been approached, but really they felt there was nothing that could be done. And she'd had palliation of her symptoms, and at that point in time, she was actually feeling quite well. So at this point, I was thinking, this is really important for us to get the right decision for this patient. And I thought, I think I know where we are. It seems straightforward. She seems to be leading us in a direction which seems quite sensible and quite logical. So at that point, I went, we've clearly been thinking about this for a bit. Do you want to actually move on to the next stage? Do you want to do the testing, or do you want to just go home now? And she was feeling quite emotional, and she was like, well, I'm here. My husband thinks I'm doing this. You think I'm doing this. I said, well, not if you don't want to. So I said, would you like to go on with the test? So at that point, she agreed. But before she even got on the bike, I said, you might not like the answer. And she went, I know, but I think perhaps I need to just explore this possibility. So she got on the bike, and actually she was pretty fit. Despite the fact that she'd had significant weight loss, she was better than her predicted values, and she performed very well. At the end of it, I then sat there and had to say, well, you know, you're actually pretty fit. If anyone was going to have this operation, you've probably got the reserves to cope with it. However, the complications are related to the surgery and not necessarily just your fitness levels, and the concerns are there from the surgical team that this could be complicated, this could be difficult, but your risk profile is less than it might be for many people. Oh, I'm not sure what to do now. I was really hoping it was going to be bad. And this seems to happen quite frequently, that patients have this difficulty, that it's much easier if they can find a solution to the problem. They don't want an operation, and if you can say, do you know what, I'm really worried, this might be high risk, they go, thank you very much, I'll take that, good night. And there we are with this lady going, well, actually, you're quite good. And she really didn't know what to do. So at that point, I thought it was time to phone a friend. She clearly wasn't going to reach a decision today, because she was so conflicted. And more importantly, I felt quite uncomfortable that perhaps her husband wasn't as clear about what the concerns and possibilities might be. So I contacted our nurse specialist, who is amazing. And I said, you've met this lady? She said, yes. What do you think we should do next? So we sat and we decided, along with the patient, that what we would do was have a meeting in another couple of days with her, with the nurse specialist, with myself and with the surgeon and her husband, and talk through everything and give them time to contemplate and for him to ask questions and for everybody to be in the picture of what was going on. We also knew that if we were going to operate, we needed to think about it sooner rather than later. So she was penciled into a date so that we had something to work towards and that this wasn't going to extend the time frame any further. So a couple of days later, we went over to the Macmillan Centre and had a chat. And she walked straight in. She bounced into the room. She was really positive. We've been talking. It's been really good. It's been really positive. I want to have the surgery. I was gobsmacked. I was floored. Myself and Claire sat and looked at each other and went, okay, are you sure? And we then spent a good period of time going through what the potential risks and problems were, making sure that they both fully understood what was being planned, what might happen, what could happen, an explanation of where she was going to go. The surgeon was there and joined in the conversation, and I was able to get the anaesthetist looking after her. He was able to come down. So everybody felt fully informed and comfortable and happy about what was going to happen. A couple of days later after that, she came in for surgery just before Christmas. She actually had a straightforward operation, as the surgeons always tell us. It was a great success. They took out most of her liver. Her end of surgery lactate was a little higher than we liked, but it wasn't too severe. A bit of blood loss, but it wasn't too significant. She was admitted to the high dependency unit. She had a little bit of metaraminol running. She was comfortable, pain-free, and quite happy. She spent a couple of days there, just weaning off the vasopressor, and then was discharged to the ward with things looking really quite positive. Unfortunately, she deteriorated, and over Christmas she became worse. So the liver function test went off, her Muse score started going off. She got scanned to make sure that there was no problem with the portal vein, that there wasn't anything we could do to intervene. And it really felt, unfortunately, that there was nothing else that could be done, that as she was suffering for a small for size liver, and she was going into liver failure. And really sadly, 3 weeks after coming in, she died on the ward. All the way through that time, she was awake. She was talking to her husband. They were having discussions with us, with the nurse specialist. She had a tiny moment of regret and admitted that maybe she had made the wrong decision. And then a couple of days later, actually, no, I tried and it didn't happen and it didn't work. We all felt really conflicted, but actually we felt really positive because here we had gone through a process. We'd given her the opportunity to explore what was important to her, to make a decision based on good evidence, and to have accepted the outcome and understand what had happened. I think if we hadn't been through this process, if she'd come in and I hadn't asked those questions, I'd have seen the results of the test, I'd have said, yeah, great, you're really fit, let's go. We wouldn't have had those discussions, we wouldn't have had those conversations. She might have felt bundled into a choice that she would have then regretted far more than the choice that she came through, even though she might have had the same choice. It just highlights, I think, this idea of patient's preference, the silent misdiagnosis that's going on out there. If we don't talk to our patients, we don't find out what's important, we look at the numbers, we make some decisions, all too often on their behalf, or steer them in a direction. And I think then we miss out this opportunity to get that bit in the middle of the Venn diagram right. So I think just in summary, I'd like to say shared decision-making is not a linear process. It doesn't have to be. You don't have to have all the answers, but you need to know who to ask the questions of. I think you need to identify in your clinics what the patient's goals and aspirations are from this. And highlighting that in your clinic letter will then help if you go back to the surgical team to explain what's important to them and to encourage the patient to ask questions of the process as well. I think local outcome data becomes helpful in your risk assessment so that you can give them as much knowledge and as information as possible. But I think finally it's also not about the numbers, it's about the conversations that we're having with our patients, and that's what's really important. Thank you very much.
And don't forget you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. ebpom.org for more details. That's ebpom.org.